The systemic phase of a malaria infection begins with sudden violence. Inside the bloodstream, the parasite replicates until the infected red blood cell physically bursts, releasing a new swarm of pathogens and triggering an immediate, overwhelming cascade of chills and high fever. This brings us to Marcus, a 52-year-old petroleum engineer presenting to the emergency department. 12 days ago, he returned from a 4-week trip to Nigeria. This geographical detail dictates the clinical approach. West Africa is a highly endemic region, accounting for roughly 70% of all imported malaria infections diagnosed in the United States. These infections are almost entirely preventable, yet they continue to occur because returning travelers frequently misunderstand how acquired immunity functions in areas of high transmission. This graphic maps the exact timeline of Marcus's infection. Notice the 12-day window following his return to the U.S. This is the asymptomatic incubation period, which perfectly aligns with the standard 8 to 25-day range for Plasmodium falciparum before symptoms spike. Once that incubation period ended, the onset was abrupt. He developed a 104.2-degree fever, profound rigors, severe frontal headache, and deep muscle pain. Marcus made a critical clinical error before his trip. Because he grew up in Nigeria, he assumed he still retained natural immunity to the disease. As a result, he skipped pre-travel medical counseling and elected not to take any preventive anti-malarial medication. Naturally acquired immunity to malaria is not a permanent state. It requires continuous, frequent exposure to the parasite to maintain. Once an individual moves out of a high-transmission endemic area, that protection wanes rapidly. His false sense of security left him completely unprotected against a life-threatening acute infection. He now requires immediate, precise diagnostic testing to identify the pathogen. Initial routine lab work shows mild thrombocytopenia and anemia. These are early hematologic indicators of malaria, prompting an immediate rapid diagnostic test. This rapid diagnostic test cassette shows 2 positive lines. The bottom line tests for the pan-malarial aldolase antigen, confirming infection with a Plasmodium species. The top line detects histidine-rich protein 2, or HRP2, a biomarker unique to Plasmodium falciparum, ruling in an acute falciparum infection. Under light microscopy, this thin blood smear definitively diagnoses the species. It shows erythrocytes containing multiple delicate ring-formed trophozoites, the morphological hallmark of P. falciparum. The 2.5% parasitemia reflects the pathogen's unique ability to invade red blood cells of all ages. Since he has no signs of severe organ failure or altered mental status, the combination of these specific biomarkers and morphological evidence confirms a diagnosis of acute, uncomplicated falciparum malaria. We can now target the parasite pharmacologically. For decades, the automatic drug of choice for treating falciparum malaria was chloroquine. Prescribing chloroquine is now a fatal error. This diagram shows the parasite's food vacuole. West African P. falciparum strains have a mutated PFCRT gene, turning their resistance transporter into an active efflux pump that aggressively ejects chloroquine, preventing lethal drug concentrations. Cleared of the drug, the parasite safely neutralizes its own toxic digestive waste and survives the treatment entirely. Because regional resistance neutralizes chloroquine monotherapy, modern treatment protocols require a dual-action weapon to successfully clear the infection. The World Health Organization and CDC standard of care is artemisinin-based combination therapy, or ACT. This prescription card shows the 2 components of coartem, artemether and lumefantrine. Together, they execute a highly coordinated vanguard and sweeper assault on the parasite. The vanguard component, artemether, freely diffuses into the acidic food vacuole. This schematic highlights its 1,2,4-trioxane ring and endoperoxide bridge. When the drug encounters massive quantities of free ferrous iron inside, physical contact instantly cleaves the endoperoxide bond, triggering the mechanism. This cleavage generates highly reactive carbon-centered free radicals. As shown, these radicals rapidly alkylate essential transport proteins, tear holes in internal organelles through lipid peroxidation, and disrupt the mitochondria. The speed is devastating, dropping total parasite biomass 10,000-fold in a single 48-hour cycle. Despite its immense lethality, artemether has an extremely short biological half-life of under an hour. If used as a monotherapy, it clears from the blood too quickly, leaving survivors. It requires a longer-acting partner to finish the job. The sweeper component, lumefantrine, is a highly lipophilic molecule that accumulates inside the food vacuole to hunt surviving parasites. As outlined here, lumefantrine binds directly to free toxic heme, physically blocking the heme polymerase enzyme from crystallizing the waste into safe hemozoin. Prevented from crystallizing its waste, the parasite experiences lethal autointoxication. This diagram illustrates the resulting massive accumulation of toxic intermediates, which inflict severe oxidative damage until the vacuolar membrane eventually ruptures. The parasite is poisoned by its own food source. This chart details the 3-day pharmacokinetic dosing architecture, highlighting the specific instruction to take the medication with a high-fat meal. Because lumefantrine is highly lipophilic, co-administration with dietary fat increases its relative bioavailability 16-fold, ensuring the drug reaches the required blocking concentrations. The success of ACT lies entirely in this synergy. Artemether acts as the vanguard to achieve a rapid, massive knockdown, while the highly bioavailable lumefantrine sweeps the remaining parasites over several days to prevent recrudescence. This 7-day timeline compares artemether's steep drop with lumefantrine's sustained concentration wave. The vanguard strike provides rapid relief in days 0 through 2. The sweeper phase takes over through day 7, where lumefantrine's concentration ultimately determines a permanent cure. For Marcus, this molecular timeline translates into a rapid expected clinical resolution. His fever and parasitemia should clear within 48 to 72 hours, effectively halting any progression to severe, life-threatening disease. However, strict patient adherence to the full through-day, twice-daily dosing schedule is the absolute requirement for bridging these pharmacokinetic curves to a successful clinical outcome. For Marcus's post-treatment protocol, we assess if he requires medications to prevent relapses. Plasmodium falciparum relies entirely on the erythrocytic cycle and lacks the dormant hepatic stage. Therefore, post-treatment anti-relapse therapy is completely unnecessary. The blood schizonticide combination alone has provided Marcus with a full, definitive cure. Successfully managing a returning traveler requires connecting their epidemiological history directly to precise molecular biomarkers and understanding how targeted pharmacology exploits the parasite's own biology to defeat evolutionary drug resistance.